Okay, so I know some of you have heard this talk a few times, and we've talked individually. I'll go through the aspects, and I'm glad it is being recorded so other people can see it, and you can also listen to it in the future. And of course, you can always contact me directly. My email address is in the foundation information. And I'll leave lots of time for questions, which reminds me, how much time do we have? Is it a half hour? What time am I to end? Okay, great, wonderful. Okay, all right, so I'll kind of talk about autism, and I know I spoke with multiple individuals yesterday about the issue of being diagnosed with autism, someone being oh, we don't diagnose autism because you have SLO, or yada, yada, yada. So autism spectrum disorder is what we call a kind of syndrome, like they did with Smith-Lemli-Opitz syndrome prior to the days of learning that it's a cholesterol deficiency disorder. It was based upon saying, okay, well, you have this in your toes and this in your face, and we're going to give you this diagnosis. And so same thing with autism. It's a characteristic of individuals who have social difficulties, communication difficulties, and unusual or repetitive behaviors. And I know the field changes the name every year, 5, 10 years. It's autism spectrum disorder, it's autism, it's PDD, which just causes quite a bit of confusion in the field. So Smith-Lemli-Opitz syndrome is one of the disorders that's associated with autism. People would say, some people, maybe they identify about 100 different disorders now that can present with symptoms consistent with autism. And the symptoms being, as I mentioned, these deficits or difficulties. So Smith-Lemli-Opitz syndrome is one of them. So yesterday I spoke with someone who said, well, my doctor I went to my neurologist and he said he wasn't going to diagnose autism because my child has SLO. Well, that's not the right thing to do, and contact me if anybody does that. It's better to say if your child meets the criteria for autism and you have SLO, then you have both diagnoses and you can hopefully get better services with those diagnoses, and with those services helping to address the difficulties. And I know you had the excellent presentations this morning on augmentative communication, which I'll touch on, and some of these various services that can help individuals with SLO. So, and this is just what I said, sorry. Okay, it's not a separate disorder, but it's these symptoms of social communication and behaviors. And it varies. Some people say 1 in 10, 1 in 50, 1 in 100. You kind of figure out what the disorder is that associated with what you call autism, being Fragile X syndrome, Rett syndrome, Smith-Lemli-Opitz syndrome. About half of individuals with SLO have been diagnosed with autism spectrum disorder, or you'll see sometimes half to 3/4 of individuals are somewhat on the spectrum. It is difficult to assess in some individuals if they don't speak, don't have as many abilities, do you make the diagnosis or not? Okay. And the reason it can be helpful is to obtain more appropriate services, such as classrooms that serve individuals with special needs or autism, because they may be more attuned to knowing how to treat behaviors that are seen. They can use visual instructions. You can do that at home, sometimes too, to help transition. So you have a board with different pictures, and you say, here's what we're going to be doing today, things like that. And they can also work on social skills training, working with I know a lot of people yesterday I spoke with are doing social stories, which is great. When there's going to be transitions, I'm hearing more and more kind of people using these various techniques. So yesterday someone asked me what do I do during a psychiatric evaluation, because they're going to have a psychiatric evaluation, was wondering what I can do. So here's kind of what I do. So I'm a psychiatrist, so I'm a physician, so part of my job is to try to figure out if there's any psychiatric and medical disorders that are presenting with symptoms. So what all of you have been through so much through your child has an increase in self-injury or difficulty, and you figure out, well, okay, what medically might be going on? Is it my child has an ear infection that can often increase head banging? So kind of my talk today, a lot of it is focusing on addressing the more severe symptoms. So if a child has a worsening of an illness, or I'm foreseeing them, I'm trying to assess what is their history of the self-injury. We talked about, had the presentation on communication augmentative speech. A lot of individuals with SLO will do self-injury for communication purposes, so it's so important to get these other things. Okay, so back to the medical things. I ask questions about, does your child have allergies, sinus infections, ear infections, GE reflux, headache, seizure disorders, constipation, pain from bowel symptoms of constipation, and are there other diagnosable physical illnesses, including thyroid difficulties? And have they been screened for thyroid abnormalities, so thyroid stimulating hormone? It's a blood test. We actually don't find many people have those disorders, but it's kind of a classic in anything psychiatric because thyroid abnormalities can worsen symptoms, be it low or high thyroid. And then, so once I kind of assess what medical conditions might be going on, then for me it helps as I try to think through what medications or interventions might help. I try to determine, are there symptoms that in psychiatry we conceptualize as disorders, and we have no blood tests for any of these disorders, unfortunately. One day, hopefully we will, but now it's kind of the dark ages of psychiatry, and you ask, are these symptoms ADHD symptoms? What age did they begin? What did it look like? It is very helpful to know if there's a family history. So I really probe families. I say, please ask your family members, tell me about Aunt so-and-so nobody talks about. And I ask, do people do things that don't make a lot of sense, like argue with a police officer or lose their job, difficulties like that help me understand whether or not there might be an underlying disorder such as bipolar disorder. And I do that for a couple of reasons. One is to try to assess, that helps me conceptualize the symptoms that are presenting in the individual I'm working with, but also if somebody has a history of bipolar disorder, you want to be extremely careful with the use of antidepressants. Because if somebody biologically is predisposed, they kind of like have a gene for it, it can make the illness come out. So one has to be quite careful with that. I ask about, and now I'll describe these disorders, the ADHD, mood disorder, to try to understand. Let me touch on it. So let's see. Oh, yeah, okay. So I'm going to pop ahead right to this one. So with these various psychiatric disorders, we make diagnoses based upon the symptoms that we see and the symptoms, the histories that you give me. So that helps me look at this. I ask about sleep. Sleep can be, SLO, right? But everybody's impaired. So it's going to be, to me, it'll help me conceptualize that there's a disorder but it's also going to help me know what target I'm going to try to help. So in SLO particularly ask about sleep because that's something that luckily we can help often. I know you had a sleep lecture already. Behavior, right? I sit down and tell you, okay, what's going on, and tell me everything bad that you can do. And usually with families with SLO, it's like, no, tell me more. His family's like, oh, he does that. I'm like, no. It's like, it's okay, because you're so used to dealing with this, right? Crisis management. It's like, oh, it's fine. Like, no, please tell me. I really want to try to fine-tune this and help. So behavior of all types, self-injury, aggression, anything that's going on that's difficult. I ask about energy levels, right? Our children with mild SLO are like little rockets, right? Like, I have one famous patient at NIH who would turn around and be all the way down and you can raise your hand if you want, but Yes, and I saw a couple of others go, yeah, me too. Yeah, I mean, just like little rockets, the mild ones. So I do conceptualize it. Generally, I've seen individuals with mild SLO can have quite severe ADHD. And it's helpful to identify that because we do have interventions for that, and I'll talk about medications in a little bit. Appetite, right? It can be often a target with low appetite. Generally, I know with some of our medicines, appetite has increased to the point where it's been difficult to deal with. Moodiness is quite frequent, as you know, and irritability, crying spells. I met with a patient yesterday who I had previously treated as my own patient and has depression now. Concentration abilities, the ability to focus, that is often a target for me. I try to improve academic abilities, so sometimes being able to kind of target and look in at focus and concentration in the school setting. And also be able to focus if someone has ADHD. And let me go for a second with, they change that name every 5-10 years as well. It was ADHD, then it was ADD, and then it's ADHD again. So attention deficit hyperactivity disorder. It is a misleading name in the sense that you don't have to be overactive, particularly in females who may be more attentional difficulties. And it is difficult in individuals with developmental disabilities sometimes to try to tease it out. And I've had some individuals, particularly girls, where maybe were inattentive, and I said, you know, when we'll go over the meds in a minute, kind of risk-benefit analysis, do we want to try to do something? And of course, the self-injury. So yes, there was a lecture from the about eye health was brought up a couple of times. So one of the things we worry about with self-injury is that if you strike your head, it can dislodge the back of the eye, the coating on the back of the eye called the retina. So if you ever, for yourselves as well, ever start to see a curtain kind of like it's getting dark, you have to go to an emergency room, an eye emergency room, preferably as soon as possible. Because if it's starting to come off, they can reattach it with a laser, but once it's totally off, you're blind. There's nothing they can do. So on our unit, we do have little like 6-year-olds who are blind, or we had a patient on a unit came in recently, it was loose on the back. So they reattach it with laser surgery. It's pretty, ophthalmology can do that pretty easily now. They can also, people say, well, no one's ever going to be able to look in my child's eye, won't help. The doctors we have at Hopkins are amazing. They can do it. And we sometimes will desensitize and do eye drops ahead of like saline. But even if they can't do that, you can check your local ophthalmology, you know, wherever they have these eye clinics and see they're able to do it. And I don't know enough about this to know if it can be everybody, but they're now doing on our patients ultrasounds of the eye. So they can just from the outside be able to see if the retina surface is anything wrong with that. And I need to learn more about that, but at least it's something you can ask about. So that's important if you do any child does any self-injury to do that if they all of a sudden don't seem to be seeing as well. So I will discuss that as kind of risk-benefit analysis and a little bit about do we do a medication for that. I ask about obsessions, this repeating, in SLO, yes, there's a lot of repetitive behaviors and stimming, right? And often, one of the things I was speaking with a researcher at NIH a couple of weeks ago who works on a receptor, meaning like a nerve ending in the skin that is the nerve, the thing that tells you whether or not you feel pressure. And that's controlled by cholesterol in the environment at that level. So it's like, oh yeah, no wonder, right? So we published in 2001 that we looked at the sensory profile in individuals with SLO, and we thank you because some of the families who participated are in this room. So I appreciate you filling out those forms. So with those forms of sensory profile, we saw that individuals with SLO have more sensory difficulties than individuals with autism, Rett syndrome, and I think it was ADHD. I think those were the groups I had in that study. And you've seen it, right? Difficulty, like with children who can pick up things but will pick it up and drop it. And sometimes families will say after they went on the cholesterol supplementation, they could tolerate it more, right? Difficulty walking on sand, grass, even sometimes through shoes, right? It's so distressing and difficult. And that you do these sensory kind of sensitivity, the OT that you've been working with occupational therapy to deal with these sensory issues can be helpful. And then we often see that individuals who have these sensory difficulties also then have sensory interests. And kind of like, it doesn't make sense, right? He won't look at that, but he wants to look at lights, or won't hold things, but then wants to rub other things. It's kind of, we see that in autism of unknown cause and other genetic disorders with autism as well. So, and then there's obsessions, which I'm seeing more in the older individuals and teens and adults who have more classic obsessive-compulsive disorder. And that, it's where so obsessions, it's normal to have some. Like you go double check the iron maybe, or I go double check that lab result. So it's, it's a good thing. It keeps us safe. We don't consider it a disorder unless it's distressing or impairing. And you're late to work because you went back to the front door 5 times to check, or it's distressing you because you hate having to do that. So I have had individuals, older individuals, like one young gentleman who asked his mom, like, hold my Game Boy because I'm going to break it. So she'd hold it, and when she did give it to him, he wanted it and he broke it. Or he asked her to come into the bathroom so he wouldn't take the door of the stall off of the bathroom while he was taking a shower. So it's where people, like I maybe feel like I just have to touch that edge for a second. So they're normal, but when they get too much or impairing, then it's just stressing. Okay. So behavioral assessment, behavioral psychology, I know is really hard to do. It's hard to get the services, and it's incredibly lengthy and difficult to go through the assessment process and then to have the follow-up. And I know it's really easy for me to say you should do this, and it's another reality to actually have it help. I am so blessed right now to work on an inpatient unit where we have people. And I will get on the website the email address for applications to our inpatient, the neurobehavioral unit. We do bring in people from all over the country, and we would take people from other countries as well to target self-injury and aggression. And we have a day hospital as well, meaning like come in for intensive, which some of our families with. I work in Baltimore. It's about an hour north of here. So we have people actually for about 4 months. So we can do very intensive behavioral management. It tends to be individuals who, can't get hospitalized elsewhere because no one would give you the service. Or, oh, I'm sorry, we don't treat children with autism, we don't hospitalize you. Like, excuse me, okay. We've had people, we took on a unit, for example, I think they were in an emergency room, an emergency department, or a casualty department, Hugh Brits, for, I think, 7 months. And they built a room for him until they took him onto our inpatient unit. And we did the behavioral assessment. We really realized he had bipolar disorder and needed a kind of a very, a combination of medications, and he did extremely well from that. So when they talk about behavioral assessment, they'll talk about the function of the behavior. They mean, how does that work for the child? Why is he doing it? Is it for communication? Like, so important to get those pictures right. So many children that sell because their receptive language is much better than their expressive, meaning they can understand, right? You can say, oh, you want to go to so-and-so, the pool. Okay, they know in a second. And it's selective, sure. Pretend you don't understand things you don't want to do, right? We all do that. But the receptive, so getting those other communication, the sign, the pictures. And now, it used to be you had to have these expensive picture boards, but now they have them for iPads, and I know lots of people in here are doing the various forms. Sometimes, and a good augmentative, a speech person who's good at doing augmentative communication, meaning these alternative extra things, will start out like, okay, you start with maybe one picture of what they call a preferred object, right, the favorite toy. And can they ask for that, and then expand to 2 pictures. And on our unit, we find some children do best on just a plain, like a wooden board with pictures. Sometimes they're photos to start, and later they can be diagrams. And now they can do so much, and they have ones where your voice can be recorded, so when you push that toy for, like bear or something, the parent's name and voice, you hear the voice as well, which helps associate along with the picture. And then some people do sign. Okay, so So the self-injury, is it for communication or attention? Lots of people. Is it for physical sensation because of maybe pain, or maybe they want deep pressure? And then this is, we said already, the picture exchange is sometimes called PECs, these different systems they have. And then, so for physical restraint, it's a bad word, but that's what it is, right? So one of the things we do on a unit to help individuals with self-injury is we often have like arm splints, and to protect the individual, because particularly we're really worried about the head with the eyes, and then we get fractures and bumps and things like that. So one of the things that can help these restraints is we often are able to have somebody in these stiff arms, and then they have stays in there, like little pieces of metal or plastic, and they can actually, the psychologist would take them out over time. And then we get lots of people to the point where they have full use of their arms, they can feed themselves and do things, but they don't do self-injury. But you take off that wrapping and they do the self-injury. So sometimes just knowing that you physically couldn't do it can be helpful. And we do have lots of people who will, and I have seen in SLO will do what we call self-restraint, like sit on their hands in the pockets, because they don't want to hit themselves. It's part of this, or I think they don't want to hit themselves, it seems. Part of this thing where it's kind of so biologically we see it. Right, so one of the things we see in SLO is that biting right here, right? Why is it there? Sometimes it's clear, close, but it's right there. We see lots of different genetic disorders that have these things like Rett syndrome, hand wringing, or other disorder where maybe you go like this. And why? I mean, where in the world it is in the brain that it's programmed to do that? We don't understand, but for this biting, sometimes we've done things such as like a leather glove, although I know that can get soaked through if somebody's mouthing a lot. Neoprene, which is the wetsuit material. We've made gloves out of that, or you could do something else, or sometimes for some individuals it might be the chewing desire, so the chewy tubes. Some families in here have had the tubes through the chew, or chew, maybe something that's, a necklace you have to be careful about. You have to be with your child, but sometimes people have maybe one pinned, or attached somehow, and they can be easily given to the individual because it does something to maybe some of that sensory. And of course, also trying to figure out, is there teething? One of the families yesterday said, well, no, I can tell when he's teething because it's all, we also have a lot of saliva, a lot of spit. Sorry, trying to think of the regular language. Saliva. Okay. All right. So next one. Okay. So then we go down to medications. So yes, I'm biased. I'm a child psychiatrist, so I prescribe medications. And I spend most of my time doing that because there's very few child psychiatrists, but there are other specialties that will help, right? Neurologists, developmental pediatricians, behavioral pediatricians, and sometimes just your GP or pediatrician, whoever you have access to. And it varies, of course, in medicine. It all depends on what kind of training we had. Do I feel like I've had enough training that I'm comfortable with it? So as many of you know, and I've talked to your clinicians around the country and the world to talk through medicines, and God bless these clinicians you have, and where there's no one else, and your GP is asking me and taking my advice. I can't imagine being a GP anyway. The amount of things that you have to know or be a pediatrician is. In my field, it's like, okay, well, we know nothing, so it makes it pretty easy. We've 3 studies, okay, all right, I can do 3 studies. So. All right, so when do I recommend a medication? Or again, with families, I consider medication trials. It's not for me to decide whether or not your child continues on the medicine. It's up to the parent to decide that they saw enough benefit, they think it's worth using. So my criteria, usually I think about it, in behavioral therapy is our first treatment in general for things, but in SLO we are already often, you're into self-injury, which means, okay, we need to do something. So my criteria would be a child suffering, are they so distressed or unhappy, like somebody maybe has depression? Are they a danger to themselves or others, which I'm thinking they're particularly the head injury, or they're aggressive, or the family life, you just can't have a normal life because the child is so So that's the impaired part, sorry. Are they impaired in school or home life? Is it interfering with their education? Is their home life, I mean, right? I mean, it's so incredibly stressful. It's bad. It's hard enough being married and not having a child than having a child or more than one child with special needs, which just ramps it up, right, 1,000 times. So those would be kind of my criteria for people to start to think about doing it. So hitting the, I talked about the eye. Of course, there can be some damage to the eardrum. That's not as often. It's really the eye is the main thing that we're worried about. You can also get traumatic brain injury, right? I mean, you can't see it in an MRI, but you worry about if my child's hitting themselves, what is this doing? You hear about soccer players, football players, so I can't do headers, so we worry about those things too, but particularly the back of the eye is the thing that we're worried about. And these, of course, all these are on your handouts, everything, all these slides. So it's a trial. It's up to the parents to see enough benefit that they think it's worth using the risk, right? If you try a medicine and it brings it down 5%, you're like, it's just not worth it. It's the hassle of going to the doctor. It's not helping enough. Hopefully the doctor will fine-tune it, and now we'll talk a little bit about the medications. So the neuroleptics, also known as antipsychotics, they're known as that because that was their first use. They were used for people who have schizophrenia, and they happen to treat, basically they treat every psychiatric disorder we have. We don't use them for every disorder because of the side effects of them. And we can fine-tune things a little bit. Like ADHD, we have better meds for ADHD. So these are used, they are, a couple of them are FDA approved, and in the US that means the Food and Drug Administration, to be used for autism. And I'm just gonna briefly comment on that because I haven't heard that yet in this meeting. Okay, so what an FDA approval means, it means that company is allowed to approve, they can advertise for that use. It doesn't mean it can't be used for anything else. It just means they can be advertised. And in the first step, it means they can be brought onto the market. So they do what they call, for example, with Risperidone, I was one of the sites that did we had a multi-site study that showed that Risperidone would be helpful for autism. That was funded by the NIH, by our US government. Later, the company came in and got our data, the company that made Risperidone was already on the market for schizophrenia, and went to the FDA and said, okay, here's this study. It worked well for autism. So now it has what we call an FDA indication for autism, which one of the things that's helpful that it has that is that the clinicians out in the community can feel a little more comfortable knowing, okay, it's not what we call off-label, meaning it's not on the label, it says you can't use it for that. So, and these are some of the medications. So Risperidone, I use that a bit because, well, partially I'm used to it. Hey, Juki. So here's my buddy. He's going to help me today. So Risperidone, I've used it a bit. I like it because of a couple of reasons. I mean, it tends to help the overactivity without sedation. It tends to have this sedation we can use a little bit more for sleep when we do it. It doesn't have there's going to be another slide about Abilify in a minute, so I'll discuss that. All of these medicines can impair a little bit the enzyme that does, and I know Juki loves being up on the platform because he was up here even when it was up here, so he's cool. So they can impair a little bit, elevate the 7-dehydrocholesterol level, the 7-DHC, but it's to a small extent. And you're kind of weighing, am I getting enough benefit? And when I've talked to Dr. Porter and Dr. Kelly and they say yes, if you need it, you need it. So I like Risperidone. It's a little bit sedating. You can give it at sleep. You can give it multiple times during the day. It doesn't have as much of the heart EKG changes that we watch for with all our psychiatric medicines. Geodon is another one. That one does change what we call the QTC, this measurement in the heart, of the heart, how fast the electrical impulse goes from one side of the heart to the other. And I'm not sure. I think I might have that in a slide. I have to look. And so one can. Oh, thank you. So one can try these various medications, and a lot of it is whatever your doctor's comfortable using. It's all trial and error. we just don't know who's going to respond to which medication ahead of time, unfortunately. Risperidone does come in a liquid, which is nice as well. It's easy to take. And I'm, happy to talk to your clinicians about the various ones. So a couple of them, some individuals have done some studies with in cells and with animal models, and found that a couple of them, like the Abilify and Haldol, can increase the 7-DHC levels more than the other neuroleptics, so they're not our first choice. But if your other ones aren't working and want to go to that, they still might help. Okay, so the side effects of neuroleptics. The reason not everybody gets these, and they're not my first go-to, although out of all my medicines, the neuroleptics, these family, are the ones that really target self-injury the best. If it's self-injury, the type that is, well, all types, but particularly what they call automatic, like we assess maybe behind a window. We have windows looking in the room. The child's doing self-injury when no one's in the room. It's not self-injury for, I'm hitting my chair because, Mom, I'm trying to get your attention. I want to go over there. I want to be fed. So we don't know how, but somehow they really target that more than our other meds, although we do, as I was talking to the families, do try to fine-tune and get the communication and use some other meds, which we'll talk about. So neuroleptics. So the side effects, you can get a temporary muscle stiffness called extrapyramidal symptoms, or EPS, where you kind of get stiff, or sometimes the eyes might roll up, and it's not a seizure if your eyes are rolling up and the child's still sitting there doing something, by definition, it's not a seizure. If you had a seizure, where your eyes both roll up, it's a generalized seizure, and you'd be out of it, so. Okay, so that can be a side effect that's temporary. We have medicines like Benadryl, diphenhydramine, or other medicines that can be used to take care of that if somebody is doing, they're gaining benefit from the medicine, and you need to have another side effect, a medicine for the side effect. Long-term, these medicines can cause what we call tardive dyskinesia. It's a movement disorder that might not go away even after you stop the medication. It's kind of classically kind of movement of the jaw. So again, it's that risk-benefit, should I use it? Sometimes with families, what we try to do is we say, okay, maybe we're going to use it now because it's an emergency. When they're younger, the self-injury might be more severe, the head banging, or they're working on the communication technique, and you say, okay, maybe I'm going to use this for temporarily, or I'm going to use it for emergency medicine or I'm traveling, something like that, where it doesn't need to be every day. So it's kind of weighing that. And so we do use these meds. We try to use the lowest dose that works well and use it for a limited amount of time. And the other thing is neuroleptic malignant syndrome. So this is a potentially fatal. You can die from it. So we tell people about it. It's maybe 1 in 100 to 1 in 1,000. It's our older class of medicines. And it's usually when you're on higher doses on multiple, but still we worry about it, particularly maybe with children with developmental disabilities might be more sensitive. I haven't seen it yet in SLO, and I hope never to. But your child would get like a fever, muscle rigidity, blood pressure fluctuates. So I tell families, if you have those kind of symptoms, call me, stop the medicine until we can assess it. If you need to go to emergency room. If anything, we always say, err on the side of caution. If you're not sure what to do, you be cautious and check it out and make sure. Okay, so in the U.S., we are able to test the blood levels of neuroleptics. I don't know their availability in UK or elsewhere. So we're it's very, very helpful, particularly on a unit, an outpatient will bring somebody in and they're not responding. We get a blood level and find out, well, their level is incredibly low. The enzyme that breaks down a lot of our medicines, it's in the P450 system, it's in the liver. Our liver breaks down most of the medicines, or a lot of the medicines we use. And you can inherit anywhere from 1 to 11 copies. So that's like inheriting 1 to 11 copies of the enzyme, the gene that codes for 7-DHC, for the enzyme for SLO, right? So an enzyme just means it's a protein in the body that does a chemical reaction. So it comes down to you can break down medicine really slowly or really quickly, and that's part of, right? It's so variable. And that just tells us at the liver level how fast you break it down. It doesn't tell us at the brain level. We still don't know why some people will respond to some medicines and not others. So, but it can be helpful sometimes for the community, and we found getting these levels in patients that children Children tend to use almost the same doses as adults, sometimes more than typical adults, because their livers are pretty healthy and break things down in general. So sometimes it's helpful for community physicians because they're like, oh, okay, I feel more comfortable, because they come in and the pediatrician's using like these micro doses that are doing very little. Okay. And sometimes insurance companies won't pay for higher doses, and if you can prove it and say, well, this is why we're going above the FDA indication. So I mentioned obsessions, compulsions briefly before. An obsession is a thought. The way we define it, it's a little different than regular language. An obsession is a thought that comes to you, like, I need to touch this. If I do it, that's the compulsion. So some of these compulsions, sometimes we see repetitive behaviors, but other times it seems to be pretty classic compulsions, like going in and closing all the doors before you leave the house. I'm talking about the children with SLO. Sure, it's switching lights on or off, and sometimes, yeah, there's stimming going on too, which may be slightly different, but kind of seems related often in autism. And then a repeating behavior, so throwing things away, or one child would empty, like, all the shampoo bottles, you know, can't have a, or half-filled mustard container, right? It's empty, so. Sometimes it's touching things, so collecting things. I have lots of patients with SLO who have to carry something. One child who had to carry a lion, like 30 years now. They have gotten to a picture of a lion, so that's good, and a Coke bottle in the other hand, right? And why these certain things, and little things like that isn't so bad, but if it gets to be like, right, collecting everything or not allowing you to throw things away, and you're getting full of stuff in the room, right? It can get in the way, and get in the way at school. Okay, so I'll talk about anxiety symptoms. So we see a lot of anxiety with SLO. And my kind of hypothesis about all of this, we have no evidence, is that in the brain, I mean, the brain is 30% cholesterol. It's all these fats in the brain, and cholesterol is really important for the use. For some of the nerves in the brain, they need cholesterol to work properly, including the ones that are medicines like Prozac, antidepressants target. So that might be why anxiety is seen in SLO. But anyway, it's seen. So, and what I've seen often, particularly individuals who are in their teens and older, is social anxiety. Now, in a typically developing individual, right, 11, in their 8, maybe they're gregarious, and all of a sudden they become 11 or 12, and they like won't talk to you. Teens start to get socially aware and start to feel other people might be judging them, their peers might be judging them, their adults, their parents. So in SLO, I see that as well. That might be, maybe that's part of the reason that there seems to be more social anxiety as you get older. Now, selective mutism I've seen in SLO down to at least age 5 or 6. One child, when he went to school, I think kindergarten was fine, but then first grade, he wouldn't talk anymore. So selective mutism, what that means is that you have the ability to speak, but you don't in certain situations. And individuals, it's often at school or somewhere else. And I was going to hand him this, but might be a little too confusing so he has something else. So selective mutism is when you can talk in some settings but not others. So this one boy with SLO, what the speech pathologist was able to do is have the child whisper. So instead, sometimes you start, this behavioral psychologist or therapist will start with whispering, and then you get louder, or then get into full speech. But what he did is, it worked out fine, but he then spoke louder, although in a whisper quality at school. But so often we can do when somebody is having these difficulties, like it doesn't make any sense why they're not speaking, is have someone help them with these kind of anxiety symptoms, like a behavioral psychologist help them. We do use medicines for obsessive-compulsive disorder and anxiety, as well as depression. I tend to, if I'm going to use one, I choose Lexapro if possible, if you have that available. The reason I use that rather than Celexa and Prozac and such is it doesn't interfere with other medicines, and that's my next slide. Okay. Oh, I thought I saw it. Yes, okay, sorry. So So these are so some of the other ones are Prozac, known as fluoxetine. You have them all written. So Lexapro is less likely to interfere with other medicines in the rate of which the medicines are broken down by the liver. Prozac does. It's nice and smooth. If you're not on a lot of other medicines, it's nice because it can build up slowly. If you forget a dose, it's okay. I mean, you can dose Prozac once a week. It's so long acting. We don't do that too often because you're giving like a week's worth at once. But Lexapro, escitalopram is less likely to interfere with the metabolism or breakdown of other medicines. Okay, so benzodiazepines. This is another medication that we use for anxiety and selective mutism. We don't tend to use them as much in either adults or children because it's a medicine. It says benzodiazepines capitalized. Sorry, I have hand-used things and I have to do things verbally with Dragon, and I guess I wanted to capitalize benzodiazepine, the voice command. That's stuck in there, sorry about that. So it's supposed to say benzodiazepines can also treat, instead of capitalize that is my command. So I know I have to be really careful. I would have these be doing emails. I learned not to put the person's address in first, because then I'm like, I want to say send it to, or it's sending a message and the thing goes. So, all right. Okay, but we do use them for anxiety sometimes, and they can be used for seizure disorders. So when clonazepam sometimes is used for seizures. It is a medicine that sometimes your body gets used to, so it might not work as well. The setting I tend to use them for, and I've used them in a number of individuals with SLO, or for traveling, or for emergencies, or for blood draws. Lorazepam, these they often use when you're going for like MRIs. There's another one, Versed, you might have heard of that. That one, you need to have an IV in, a line intravenous. So there's some you use in different settings. I use kind of a lower dose. Like my usual maximum is half of what would be conscious, what we call conscious sedation, meaning you're using it for an MRI or something like that. So, okay, all right. So some other strategies we can do for stressful or loud events. DVDs, right? Oh my gosh, the world's greatest invention, the portable DVD player. So use that if you're in a stressful or maybe going to be a loud event. Sometimes if you're going to be somewhere where the child can't really see it, but they like music, then maybe have music with headphones so to help block out those other noises. We had one child who would elope all the time. One of the treatments they did is his parent would have the device. And the child had the earphones. If they ran, they couldn't hear the music anymore. That helped a little bit. Some of the other strategies we can do is move some dose times around. A lot of our medicines, like the Risperidone, are longer acting, and you have some flexibility in moving dose times around. So if somebody's going to be traveling, maybe I can say, okay, give all the evening dose in the morning at the airport, or you're going to be a stressful event. There's often a lot of flexibility about when you move these, even though it might say, oh, you give them the AM. If somebody's, that's for example, Guanfacine, which I will talk about in a minute, so I'll get to that. And that one's we can move around. And then Benadryl and some other things. So travel, medical procedures, blood draws, I wrote down there my usual maximum. And then it kind of comes down, the dose works out about 0.01 milligrams for every pound. Okay. And then with Ativan, you have to wait about 4 hours between doses if you're on the higher range. Okay. So these are for mood disorders, it's the same meds as pretty much your list that was on the OCD and anxiety. We do use maybe a few others, Wellbutrin. There's a lot of antidepressants now. If one doesn't work, there's another one you can go to. And then they have these slightly different classes. You'll hear SNRI or SSRI. There's different receptors in the brain. Again, it's all trial and error, unfortunately. Sometimes I find it helpful to know what maybe someone else in the family responded well to. Like, oh, my sister did really well on Zoloft. So I'm like, okay, we'll try Zoloft. Then other things we can do are sometimes if people have a seasonal depression, like they feel worse in the winter or summer, and you can do a light box, and that's something to discuss with the doctor. Again, if there's bipolar disorder, you want to be careful about that. Exercise and also diet, healthy diet can be helpful for depression, particularly exercise in the morning, getting the light. Being careful with sleep. Yeah, I'm telling this to family with SLO, right? So, okay, that doesn't go so well. But in general, we try to tell people, warning them anyway about blue light of phones and computer screens that can interfere with the body's natural cycle of melatonin. So I mentioned bipolar disorder. Again, it's an illness in which people can feel. It's a medical illness. It's also known as manic depressive disorder. You can have like mild variants. You can have really severe variants. Some people are hospitalized or suicidal or try to hurt themselves. Other people have just maybe difficulty in relationships and work, and that's something a psychiatrist can help tease out, or a psychologist. So lots of our individuals with developmental difficulties and disorders have a lot of mood symptoms, even if there's no family history of bipolar. There's some kind of mood instability. In typically developing individuals, there's a lot of mood instability in childhood and teen years, particularly anyway. And the field we don't really understand it very well. We invented a new disorder a couple of years ago called disruptive mood dysregulation disorder for individuals who look like they had bipolar, but the criteria, right, the DSM, this book, the criteria they had was for adults, meaning, again, all these disorders in psychiatry, it's like, okay, over the past 100 years, we've kind of put together that if you have these symptoms, this is what we're going to call it. No diagnostic blood tests. We do test for medical disorders that look, present with it. But so individuals often have a lot of mood instability, teens anyway, and they sometimes will come out of it later, and we don't really understand it. But we have medications for that kind of mood instability or bipolar-like symptoms, and they're lithium, Depakote. Lots, patients in here I've treated in the past have been on some of these medicines. And some of these medicines, the majority of our medicines, everything but the lithium, everything else on that list also treats seizures. Now, different seizure types, there's different kinds of seizures need different medicines, so they don't all treat the same seizures, but in general, sometimes they'll be called a seizure medicine. You're like, wait, my child doesn't have seizures. Why are you giving me this? So it's to try to treat mood instability. Okay, so the other thing I ask a lot about are attention deficit hyperactivity disorder for a couple of reasons. One is that if there's these symptoms going on, yes, it's interfering. Often people come to me because there's some behavioral difficulty. They're impaired enough that they come and nip on my door. So I ask about these to try to figure out the impairment at school, but also we want to try to help academically if we can. So ADHD is a syndrome where there's attentional difficulties. There can be overactivity. Girls don't always have that. Girls tend to have maybe more attention. They still are a little bit more impulsive than someone who doesn't have ADHD often. One of the things also about ADHD, let's say, in a typically developing individual, we know that ADHD can be more impulsive. The part of the brain, what we call executive functioning, that helps process things and attend to things also helps with our judgment and impulse control and mood ability. So children with ADHD tend to be maybe a little moodier, and in medicine they may be less because they can kind of process that. That part of the brain is working a little bit more effectively. So it can be just people maybe looking around and not attending to things as well, like in school, like somebody said yesterday, well, he's looking at the guinea pig. Why did you put him in the classroom with a guinea pig? Yes, I mean, it's a distractibility where children with ADHD do great watching their DVDs. They can attend if they want. It's more an issue often of distractibility, where if there's a noise or something interesting, it's a little harder to stay on track. And even the video, sometimes you go off to wander and do something else. So one of the things in SLO is inattention may be due to delayed processing time as well. Meaning we have a bunch of disorders like Rett syndrome. I see this a lot too, where individuals, you have to say, well, wait a minute, you're going too fast. Give them a chance to respond, right? So even though children with SLO tend to better receptive processing, meaning they can hear what you're saying, then they're expressive, meaning they can speak, so they can hear what they're saying, but still give them a little bit extra time to process. And sometimes the teachers, you build that into your school plan, the IEP, to say, no, give a little, don't go so fast. Give her time to give you the answer. Okay, so if one does want to do a medication, again, usually if somebody's impaired in some way, either academically or they're running out of the classroom, it's a safety issue often in ADHD. You have children climbing up walls, eloping from the house, safety issue. Then some of the medicines we try, I often try the family of what we call stimulants. We did a double-blind placebo-controlled study in autism. We mean half people on a placebo, fake medicine, half on real. And we found half the children with autism did actually respond well to it. So that's a lot less than the 3/4 in typically developing children, but it's still enough that I'll tell families, yeah, well, you have a chance of getting worse on it, have a chance of maybe improving. Do you want to do this trial? It's out of your system by the end of the day, so you try it when you're at home and you're not going somewhere new or anything like that. You do it safely. So sometimes I have used in individuals with SLO to some success to help focus and attention, concentration. And then I just list the various ones that you might hear, Dexter and Adderall, Vyvanse, and such. Okay, so then my other ones, Clonidine and Guanfacine, are very similar to one another. They're just slightly different ends of the nerves that they work on. Intuitive, you may hear that word a bit. That's a long-acting form of Guanfacine. It's the trade name. The other trade name is 10X, is for just the plain release. This is a medicine we've been using in psychiatry for about 20 years at least. It was marketed for high blood pressure first, and it tends to, if you have high blood pressure, it brings it down to normal. But if you have no normal blood pressure, it doesn't usually lower it too much, although that is something to watch for as you get higher doses, or if your child is on it, because I know it's really hard to get blood pressure, right? And you're like, can I use this? Is you go up slowly, and if your child looks any episodes where like they're going from a sit to a stand, and all of a sudden they look tired or they look unsteady, then the blood pressure may be a little bit too low. I do have norms for low blood pressure, meaning the low range of blood pressure. So in our main pediatric books, I couldn't find anywhere low. They all have the chart for high blood pressure. So, but they have in the US, they have a study of tens of thousands of children, typically developing children, so we know what the normal low blood pressure is for children, and I'll work with Kate, somebody to figure out, we can put that on the website, maybe. So, and that's been very helpful to give that clinicians, because the pediatricians are out there like, I don't know, and they're using what we think as an adult, we say this is too low. On our inpatient unit, we use that. We'll know the first night the nurse will call and say, okay, can I give it? His blood pressure's lower than what you say, and you look at the table, oh, no wonder, yeah, it's really 20 points less is what the normal is. So Guanfacine, so these medicines, the Clonidine and Guanfacine, are used for ADHD. They're FDA approved for ADHD. I spoke with someone else, their child's on the Intuitive, the long-acting Guanfacine, and they were on 4 milligrams, and it has changed, the FDA. It used to say 4, but now it's 7 milligrams is the maximum, because somebody did a study and said, well, actually, we dosed children, we watched them carefully, their blood pressure were fine, and they're actually on that new. If you ever want to if you're on a medicine, you want to find information, if you Google the name of the medicine, then FDA, that should bring it up, or FDA PDF. It will bring up the prescribing information, a PDF document that gives you all the information, which is like, unfortunately, kind of like Googling Dr. Google I've done. It's like, you don't want to do that, right? You don't want to read about all the side effects. But so if you do want to look at side effects, look at the placebo versus the active medicine, because you'll see the placebo had like huge amount of side effects too. So that gives you a better sense of, is it really a side effect of the medicine, or people just didn't do that well that day on it. So our old medicines don't have the placebo data, unfortunately. So, okay, and I'm talking a lot about Guanfacine, but I like it. So, all right. So it's good for a couple of reasons. It tends to help overactivity and impulsivity. It can help sleep. It works really nicely for anxiety. It doesn't have an FDA indication for anxiety, but when I use it, in typically developing individuals as well as SLO, it tends to kind of calm everything down. So the side effects we watch for are blood pressure too low or heart rate too low, but your doctor can start a dose and go along with it. And the other thing is pediatricians are very comfortable with these usually. They're very comfortable with the stimulants in general as well. They're not very comfortable with neuroleptics. A lot of them aren't trained with that. I also do use two of these together sometimes, and I tell people ahead of time, someone's going to tell you that's not right to do, but here's the rationale. They're very similar. Clonidine is shorter acting. Guanfacine is longer. Guanfacine can be used once a day. Even the regular release guanfacine, not just the intuitive, the regular release is marketed for once a day once a day for high blood pressure in adults. Children, we sometimes would do twice a day maybe because they maybe break it down a little bit faster. So I'll sometimes use clonidine for sleep, to induce sleep if somebody's having a hard time sleeping, while I might be using guanfacine to stay asleep or the next morning. And sometimes if people are doing well with it, a little too sleepy, I might dose it just at night and not in the morning. So there's a lot of flexibility as to if you're giving it in the morning or not. It's with every child, it's kind of trying to find that sweet spot where you're getting a response but not a side effect. Like you're calm, can focus, but you're not sleepy. And sometimes it means maybe going up a little slower, moving dose times around, kind of. I would say don't give up, talk to your doctor and say, is there something we can do with this? I see something, but can we kind of finesse this a little bit and try to make this work better? Strattera is another medicine for attention. It's actually an antidepressant, so it's another one to be very careful about if there's a family history of bipolar disorder. All right, so some other techniques we'll use strategies that I'll just end with this before we go to questions. I mentioned a little bit about using medicines for getting blood tests. You can use lorazepam if your doctor's willing to do that, or sometimes move. If your child's taking a medicine that tends to calm them, sometimes you can move the evening dose to the morning, things like that. But for other strategies for blood tests, and even if the child's not bothered by it, but to maybe over time not develop a fear of needles or something, is using something that will numb the skin, like before a vaccine. You can do different products. It was actually someone, I think, when an SLO parent told me about this pain ease to numb the skin. You can use Emla cream, which is another numbing. It's lidocaine, kind of like you think about like a dentist injects. It's that same family. One thing, if somebody has really difficult to get to the veins, it can make it a little more difficult. But if they have great veins and you don't have to worry, then you can do that. The other thing important to do, if you're going for a blood test in the morning, your doctor might want the child to fast. So that means anything but water. Try to get lots of fluids in because that will help plump up the blood vessel. So, all right. Questions? Yes, and if you would please come to the mic so we can get it on the, everyone can hear it and it'll be on the video feed.
So if I go on Amazon and buy this pain ease spray, how soon do I spray it on before the blood draw?
I don't know for the pain ease. I think it's pretty quick. It should tell you. I can tell you for the Emla because I prescribed that, so I know that. Emla cream is about an hour before. Yeah, I think the family, maybe somebody else can help me in here. I think that spray is just before, and I think the Noahs have used it. Yeah, just before, right? Yeah, she said yes. So, and you are able to use both together. Yes, next question.
Hi, I have a question. We work with a developmental pediatrician who does a lot of our medication management. If we wanted to have them consult with you, would you need to see our daughter first?
No.
Okay.
That's fine.
So they could
just
do a consultation.
email me. What I will want to do is talk to you first at length to try to understand the issues. And if you want help going for an appointment, please contact me ahead of time. so that I can kind of figure out what's going on, and I can know what the history is of what meds you've tried and things
Right.
like that.
And I did just want to, I don't know if you had experienced this, but she's been, I mean, we were going down the list of all the medications that, we've been on that, we've been on that, we've been on that. The Tenex with her, it actually caused her heart to race. I don't know if you've ever experienced that.
I haven't seen
Her blood
that.
pressure was fine, it was never too low, but she actually is, she's very verbal. She was able to tell her teacher in school that it felt like her heart was beating.
Now, usually it lowers heart rate. I don't
know.
know if it was a compensatory, if her blood pressure was lower and the heart was going fast for that reason.
Yeah.
I'll have to read up on that and understand that better.
Just wanted to mention that.
Thank you. Yeah, and with these, excellent, thank you. Any other questions? I know, yes.
Thank you, Dr. Tierney. I had a question about with the neuroleptics and the tardive dyskinesia. Is that something that could start at any time, or would it only be at the beginning of treatment?
Thank you. It's not usually at the beginning. For most people, it can be after a few years, but some people with developmental disabilities seem more sensitive. And please, any other physicians or clinicians or psychologists, if you want to add anything as we go along. I have seen it in people earlier, like within a few months.
Okay, so we need to.
Although it's, sorry, so in that sense, when it first shows up the movement, it usually will stop when you go off the medicine or switch. Sometimes we will switch medicines.
Okay.
And did you want to add, please? And come, yeah.
So I just wanted to say that in case it does persist, there is now actually recently been a drug approved for tardive dyskinesia on the market. So it is something that, if it is very bothersome, can be attempted to be treated with that drug.
Thank you. And they sometimes will use some evidence for vitamin B6. So, any other questions? I know we did a lot of one-on-one sessions, so people asked many that. Yes.
I don't know if Chandler's the only one that does this with the Risperidone. But remember when she started getting the stiff arms
stiffness.
and the legs, and that's why you had us put her on Benadryl, which counteracts whatever it makes her do this. She would scream, her right side would do it, or all four limbs would stiffen up, and it was painful, like a cramp. And when it first happened, I took her to Texas Children's, and they were like, it was the second time it happened, because you had mentioned Benadryl, and I said, just give her some Benadryl, let's see what happens. And she was fine, and they were like, how'd you know that?
Yeah, that's what we call the extrapyramidal symptoms, the EPS.
What is it?
Oh, the extrapyramidal symptoms, or EPS. So thank you for describing that.
Very
Sometimes
painful
it's
for her.
the eyes can be, yeah, so for her was sensitive. She didn't have the eyes. The muscle on the top of the eye is one of her most sensitive muscles to that side effect. So that's often what we might see a little bit. Like the eye will go up for a minute and then maybe come down. But yeah, stiffness there. It can be like a stiff, like pulling to the side, something like that. Any other questions or any other comments from Audrey or Simona? No? Okay, thanks. All right, thank you.